In this video, we'll talk about loop diuretics, which includes furosemide, bumetanide, torsemide, and ethacrynic acid. If you're wondering why ethacrynic acid doesn't follow the traditional pattern of the "ide" suffix for our loop diuretics, that's because it's unique in that it's our only non-sulfa drug of the class. So if we have a patient with a sulfa allergy, ethacrynic acid is what we'll use. Our loop diuretics will be working on the thick ascending loop of Henle on the sodium-potassium chloride cotransporter. In order to understand the mechanism of our loop diuretics, let's see what the thick ascending limb is doing when it's not being inhibited. So usually we have this NKCC transporter that's going to reabsorb sodium, potassium, and 2 chlorides from the lumen into the cell. Once inside the cell, our sodium-potassium pump will kick sodium out into the interstitial space, and at the same time, we're taking in even more potassium into the cell. So this is going to cause a concentration gradient that's going to want it to exit the cell back into the lumen through its potassium transporter. Chloride has a similar transporter, but it's going to be on the opposite side so that it can build up in the interstitial space. So the big takeaway of what our thick ascending limb is going to do when it's not being inhibited by loop diuretics is it's going to build up this salt in the interstitial space. Now we know that water likes to follow salt, but our thick ascending limb is impermeable to water. So it's going to come from the descending loop of Henle. And this is the countercurrent multiplier system that's going to be concentrating our urine through kicking out solutes in the thick ascending limb and having water follow them in the descending limb. Something else our thick ascending limb accomplishes is it creates a positive charge in the lumen. That's through reabsorbing 2 negatively charged chloride anions from the lumen into the cell while kicking out our positively charged potassium. This is important because that positive charge is going to repel our positively charged magnesium and calcium to want to exit the lumen and go into our interstitial space. And it does this through squeezing between the cells of our thick ascending limb. So what happens if our loop diuretics come and bind to our sodium potassium chloride cotransporter? Well, the big takeaway is that there's going to be less salt reabsorption. So there's going to be more salt back in our lumen, and that's going to take away the driving force for the water in the descending limb to want to exit the lumen and enter back into our circulation. So to sum it up, there's going to be less salt reabsorption in thick ascending limb, and therefore there will be less water reabsorption in the descending limb. And when there's less water reabsorption, that means there's less water in our blood volume, so a decrease in our blood volume ultimately leads to a decreased blood pressure. A secondary effect is since we have our chloride back in our lumen, which is negatively charged, and we're also going to have less potassium secretion into the lumen, that's going to take away the driving force for our magnesium and calcium. So they're no longer going to be repelled through the cells of the thick ascending limb, and that's going to keep them in the lumen, and eventually they're going to be excreted out in the urine. Loop diuretics are very commonly used in clinical practice, and that's due to their ability to decrease blood volume and decrease blood pressure. This is going to be extremely useful in a patient who presents with edema, whether peripheral or pulmonary, because we're going to be able to flush out all that excess water and fluid that's building up in the extracellular space. When treating certain cases of hypertension, it's very useful that we're able to decrease blood pressure while maintaining our GFR. So in certain cases, such as renal stenosis, you're going to have less blood flow to the kidney, and therefore you're going to secrete more renin, which leads to more angiotensin II, and that's going to constrict the efferent arteriole. So in a case of renal stenosis, we're going to have increased GFR. And that increased GFR is vital to the patient because they need that increased GFR for the kidneys to continue to function properly. So when we're using a loop diuretic to treat hypertension in a patient with renal stenosis, we'll be able to decrease the blood pressure while maintaining that GFR. We use loop diuretics in conditions of heart failure because we have an already weak heart that isn't able to properly pump all the fluid that's coming to it back out to the body. This leads to edema when there's a fluid buildup, and that can be prevented if we decrease the preload or we decrease the amount of blood going to the heart. And loop diuretics can accomplish this effectively. We can also use loop diuretics to treat electrolyte balance, specifically hypercalcemia, hypermagnesemia, and hyperkalemia. So if you recall, we're going to have less chloride reabsorption. So there's going to be more chloride in the lumen. And since chloride is negatively charged, there's going to be less of a positive charge in the lumen. And therefore, calcium and magnesium are no longer repelled to squeeze through the cells of the thick ascending limb, and they're no longer going to be reabsorbed. So if we have a higher amount of calcium and magnesium being excreted in the urine, that can treat a condition where there's too much of them in the blood. We can treat hyperkalemia because there's no longer going to be activity of the sodium-potassium chloride cotransporter, which includes the reabsorption of potassium. On to the first practice question: which of the following is a loop diuretic? All right, so let's go through our answer choices. Choice A, hydrochlorothiazide, is a diuretic, but it's not a loop diuretic. It is a thiazide diuretic that's going to be working in the distal convoluted tubule, not in the thick ascending limb of the loop of Henle. Choice B, spironolactone, that's going to be a aldosterone antagonist, also classified as a potassium-sparing diuretic, but it's not a loop diuretic. Choice C is our loop diuretic. Remember to look for that "ide" suffix, with the exception of ethacrynic acid. And remember that furosemide, bumetanide, and torsemide all contain sulfa. So if we have a patient with a sulfa allergy, we're going to use ethacrynic acid. In choice D, this is a ACE inhibitor. Question 2, loop diuretics primarily act on which part of the nephron? Well, we can instantly rule out choices A and D because we didn't talk about the PCT or the collecting duct. We did talk about both B and C, the descending limb and the ascending limb of the loop of Henle. But remember, it was the sodium potassium chloride cotransporter in the thick ascending limb of the loop of Henle that our loop diuretics are going to act on. There's going to be a secondary effect in the descending limb because that's where our water reabsorption is going to take place. And that process is going to be inhibited indirectly. Last question. Loop diuretics inhibit the reabsorption of which of these electrolytes in the kidneys? Well, for this question, we just have to remember what our target is going to be. And that's going to be our NKCC. And what does that stand for? Sodium, potassium, chloride, cotransporter. So the correct answer is going to be A, sodium and chloride. What's the third ion that will be reabsorbing? Well, it is potassium, but this is not the right answer because we are not reabsorbing bicarbonate.